Welcome everyone. Thank you for joining us tonight on the webinar, and a special welcome to those joining us on YouTube. My name is Trina Becker and this is Beth Bergstrom, and we are your presenters tonight for the EPIC Case Studies mini-series. This course is 60 minutes and will be offered for 0.1 ASHA CEUs. Just a little bit about ourselves. Beth and I are both professors and clinical supervisors at Eastern Illinois University. And we have financial disclosures we have intellectual property rights and royalties from B&B SLP Teachers Pay Teachers Store, as well as B&B Boutique website. And we do not have any relevant non-financial disclosures. So without further ado, let's start our presentation for this evening. Okay, we are going to be talking tonight about EPIC case studies, specifically articulation structure. Our learning objectives for tonight, we hope that you will be able to critically analyze case history and other information to determine etiology or underlying factors of symptoms by the end of this course. We hope that you can develop a profile of strengths, needs, and functional impact to determine treatment priorities and determine the most effective treatment approach using client values, clinical judgment, and research. So our entire mini-series on these EPIC case studies stems from the idea of we want you to understand the process of going through a case from the very beginning, talking about etiology, developing a profile through your assessment information, thinking about the impact that the disorder area has on the client, to then arrive at client-specific intervention using your evidence base, using your clinical judgment, and using information specific to that client. So we took this model from the ICF framework developed by the World Health Organization, and also ASHA talks about the ICF framework on their website and suggests that we use it to help us come to the conclusion of a client-specific intervention approach, thinking about the whole picture of the client. So we use that to help us develop our EPIC worksheet, which we're going to use with every single case. So you have that as a handout. You have a blank one, and you have the one that we have filled out on this case that we will be going through tonight. Also, before we get started, we wanted to talk about the copycat. We're going to be referring to this a couple of times throughout the presentation. This is a differential diagnostic tool for speech sound disorders that Beth and I created, and we're going to incorporate portions of that into the profile piece as we start to really think about the whole picture of the client. So it helps you pull information from case history, it pulls information from the oral mech, helps you analyze the errors, and then helps you arrive at your diagnostic conclusion, thinking about the distinctive and descriptive characteristics of a speech sound disorder. So that is what we're going to refer to. If we mention copycat, that's what that is. We do have that available on our Teachers Pay Teachers store. Okay, we're talking tonight about articulation structure. The client that we're going to be talking about is V, and he is age 6, and he came to us with the complaint of intelligibility of speech. So parents were concerned about his speech intelligibility, and we're seeking intervention to improve that. So in our university clinic, we have all families fill out a case history form. And so we reviewed that form, as well as some reports from the other professionals that they gave us gave us permission to contact to get their reports. So we found out from the case history form that V was born with cleft lip and cleft palate, and that he had PE tubes placed at 4 months. He had infant feeding therapy due to his cleft, and more recently, his parents described him as a picky and messy eater, and overall was delayed in speech and language. The reports from other professionals indicated that he receives OT for fine motor, and he receives therapy from an SLP at a hospital, and they had given him a diagnosis of childhood apraxia of speech. And he was also given an AAC device at age 4. So he had funding for a device, and that was around age 4 to help with his expressive communication because he was so difficult to understand. We also had a report from a behavioral pediatrician, and that pediatrician listed the diagnoses of childhood apraxia of speech, cleft lip and palate, expressive speech delay, and sensory processing disorder. So what is our takeaway from all of this background information? Some of the key findings that we want to consider as a part of that diagnosis is that V was born with cleft lip and palate. That's really important information.
It's kind of the mic drop of the,
right.
of the whole case. Yeah.
The need for PE tubes at 4 months. And we had some contradictions in diagnoses. So the hospital SLP diagnosed childhood apraxia of speech. The behavioral pediatrician diagnosed childhood apraxia of speech, but also listed cleft lip, cleft palate. So we have some contradictory info there.
Okay, taking a look at, continuing with the profile and taking a look at the oral mech for V. In the history, we know that he has cleft lip and palate, so that's a pretty important oral mech information. That cleft lip was repaired at about 4 months and the cleft palate was repaired around 11 months. So basically what we know from that information is that for 11 months, V had no muscle insertion for closing the velopharyngeal port. So he did not have an environment that was conducive to producing oral sounds. Raising and lowering velopharyngeal or for the pharyngeal area. So none of that was available to him until after his repair at 11 months. Structurally, we know that he has concerns with symmetry in his nose and in his lips. There are some pictures below that kind of show you what that symmetry looks like. You can see that, getting full and complete bilabial closure is difficult for him because of structure. Also, some concerns with the shape of his hard palate and alveolar ridge. And again, we know because of his cleft lip and cleft palate repair that he went 11 months with no real place for anterior articulatory contact. So, those are all things that we need to be thinking about as we move toward assessment. Functionally, we know that he had imprecise consonants. He had some drooling beyond 2 years. He uses his tongue blade and does not use his tongue tip for articulatory contacts. And he has resonance issues post his surgical repair. With regards to dentition, you can again kind of take a look at the pictures below and recognize that he's got some bite issues, difficulty with his alveolar ridge or problems there. He has some malocclusions. And then with respiration, he has weak pressure consonants. So again, in looking at the pictures below, you can see just, take a look at some of the pictures of structure and think, what might be difficult for him because of his structural deficits or deviations. And then also just looking at the picture of the cleft palate to the side, to the right, remind yourself that prior to surgery, he had no muscle insertion. So there was no movement of all of those necessary articulators and valves for closing off that velopharyngeal port. So he, learned a lot of distortions and deviations in that first 11 months.
Yeah, and I think about, this oral mech and how important it is to really look at all of those things. And it just screams structure, right? If you're really looking in his mouth and really paying attention to that history. One thing, and I think it's interesting that you said, was about how his cleft palate repair was at 11 months. And I think that SLPs might think, well, gosh, it was at 11 months. It was before he even started saying words. So how is that impacting his speech development? But I think it was important to hear you say he had that 11 months where he was, didn't have appropriate contact.
Yeah.
And he's babbling during that time.
And what sounds are they babbling during that first 9 months? A lot of bilabials, a lot of the K's and G's, the ga goo goo type things. But as they sit up, then they start to use more of those anterior sounds for babbling. And, V was not going to be using those because he did not have closure of that bilabial valve. He did not have closure of the velopharyngeal port. So he was only learning to make sounds where he could get some closure. And that was in the back of his mouth. So it's just completely, bad habits were learned because he was unable to use anterior placements for the babbling that was age appropriate or developmentally appropriate for him. So he learned a lot of bad habits. And that leads us right into thinking about the assessment. So, as we talk about how to choose assessments, I will tell you that the SPAT-D is something that has been proven to be a good tool for kids with cleft palate because you're able to really kind of look at the errors that are typically made by kids with cleft palate and really think about distortions. So the SPAT-D was chosen as well as just a connected speech sample, and a lot of syllable repetitions were chosen for him as well. But I'm also, as I'm starting to do those things, I'm really thinking about the kinds of errors that I expect to
I
hear.
think that's important.
Yeah. And again, knowing about someone just asked the SPAT-D. It's the SPAT-D3. That's the correct spelling, SPAT hyphen D3. That's correct. So I'm starting to think about what does his oral mechanism look like now, and what did it look like previously, and what kind of errors do I expect? I also know about cleft palate, in just digging into it a little bit, that they have a lot of compensatory errors. And so I need to familiarize myself with what those compensatory errors might be as I start to listen to his productions on the assessment protocol.
So you have a pretty trained ear for cleft palate speech because you have a lot of experience in that. So for an SLP that, gets this kid on their caseload and they're planning their articulation assessment, how important is it that they really think about the types of errors they might see for cleft palate?
Yeah, not only is it important to think about, but you might even want to say, okay, I have cleft lip and palate in my history. I probably need to seek out some videos so I can hear what some of these errors are. Because if you don't have a trained ear, you really throw your hands up and go, I don't know what it was. And now I know that because we have students who are in charge of providing these evaluations and assessments. And they're like, I'm not sure what I heard.
Yeah. And I think sometimes you're like, what? It sounded close to a, and you're going to list that consonant. It sounded close to it. So I'm just going to go ahead and give them credit for that because you're really not sure what they're doing. So we talked about looking up on YouTube some cleft palate speech videos to familiarize yourself with what to listen for.
Yeah.
Again, if you don't look at that case history and you don't look in his mouth, because surely you would know if you did an oral mech that this kiddo had a repaired cleft lip and palate.
And even repaired, you can look at his pictures that we showed you and know that there's something going on. So really, no excuse if you're, getting him in kindergarten and don't have a good oral case history. You still know by looking at V that there was something going on, and you probably ought to ask some questions. As far as training your ear, again, I think the most important thing is just to recognize, okay, this is not a typical error, a typical artic error, a typical phonological error. This is something different. That's going to jump out at you fairly quickly when you hear him talk. Knowing exactly how to score that or to transcribe that, you can do that later. You can take the video, come back, and then work at your own pace to kind of transcribe those errors using information that you learn.
And you use the SPAT-D, but you could definitely use other articulation assessments that you have on hand, or even the HAP, because the point is you're just transcribing the errors, right? And you're listening for those errors. So
yeah,
it's nice to know that the SPAT-D, though, is recommended.
It's proven, yeah. There's another Iowa pressure articulation test. I've never seen the Iowa pressure articulation test, but if you look it up, it's probably the #1 test. But even the cleft palate team, in our state hospital, Shriners Hospital, they use the SPAT-D, and so that was good enough for me, and I tend to use that most often. It's also just kind of a cute little fun one with a dog, and so kids really are motivated to label the pictures for you.
Okay.
Okay.
Should we look at the results?
Yes, let's take a look. Okay. Before we move on to the next one, I was just going to give you guys a quick definition of compensatory articulation errors. You heard me say that. Those are learned substitutions or deviations in speech sound production that occur when the articulatory placement is altered. It's often in response to structural abnormalities, which totally describes what we're talking about with cleft palate or velopharyngeal dysfunction. Compensatory errors, unlike obligatory or anatomical errors that you cannot fix with speech therapy, only surgical management, these compensatory articulation errors must be treated with speech therapy. If you're going to remediate them, it requires speech therapy. So the other thing that you see here that you're going to see on some videos moving forward are some of the phonetic transcription for the compensatory errors. And also, I just like this visual. You're going to see it again so that you can think about where are they making that sound versus where should that sound be made.
Okay, so go over those terms real quick.
Oh, the pharyngeal affricate is the first one. Pharyngeal fricative, mid-dorsum palatal stops. We're going to see examples of all three of those, all four of these. And then the final phonetic transcription that you'll often see is a glottal stop, which looks like the pharyngeal affricate, but without the little bar at the bottom. I just didn't put that one because you won't see any on his actual transcription. But pharyngeal affricates and pharyngeal fricatives are made further back in your mouth versus, in their appropriate place for affricates and fricatives. Mid-dorsum palatal stops are exactly what they sound like. It's a stop right at the top of your mouth, kind of where you would make your S and Z. And they often sound like a combination of K and T or D and G. You're like, did I just hear a D or did I hear a G? The reason that you're not sure is because they're not making it in either one of those appropriate places, but they're stopping it at the mid-dorsum palate. So you will hear those as we do a few examples for you.
Okay.
Okay.
Let's listen.
All right. So again, what you're looking at is we're going to watch a little video. You're going to listen. It's a very, very short clip, and I can play it more than once if I need to. But as you're listening, look at the transcription and match it to the phonetic transcription to the left. And then also think about where he might be making those errors. One thing I tell my students as they are transcribing is to have the child say the sound more than once so they can really get a good feeling for it and actually try to say it themselves in their own mouth to feel where those placements might be. Not only should you be listening, but you should be looking to see where the production is. Okay. Here we go. The target here is Cookie. He sees a picture of Cookie. I want you to hear his first attempt, and then you're going to hear a model, and you can judge his stimulability after the model.
Dodo.
What is he eating?
Dodo. Dodo.
He's eating cookies.
Dirty.
Oh, wow.
Dirty.
What is he eating?
Dirty. Dirty. Dirty.
Oh, thank you.
Okay, so you heard his first attempt. He showed him a picture of Cookie, and he said something that sounded a little bit like da-da or da-do. There was nothing recognizable with regards to the word cookie. Given a model, he's like, oh yeah, let me try something else. And he tried to give you the K, and he also then tried to put the S on the end. So the K initial and the K medial both sounded more like a mid-dorsum palatal stop. You're like, it's kind of close, but it's definitely not right. And then you heard what would be a pharyngeal fricative at the end of the word. So I'm going to play it one more time for you.
What is he eating?
Turtle. Turtle.
He's eating cookies.
Dirty.
Oh, wow.
Dirty.
What is he eating?
Dirty. Dirty. Dirty.
Oh, thank you.
If you were scoring that, would you have done a D and a T? D initial, T medial?
You know what I got stuck on for
What?
a second? I got stuck on the beginning. Was he trying to say circle, or do you think he was saying cookies? Circle? I don't know.
Yeah.
Sorry, I
think it was-
got stuck on that, and then
Really?
yeah,
Okay. But see, still, you would have thought you almost felt like D
I almost
at
felt
the
like D.
beginning and almost T in medial. Had you not been thinking about compensatory misarticulation errors, what would you transcribe that as? What would you have done?
Mhm.
You know? Okay. Next example.
Turtle.
Okay, this example is actually not one of the compensatory misarticulation errors, but more of a resonance error. This is an example of a weak pressure consonant. So instead of that high pressure consonant B, you're going to hear him substitute a low pressure consonant M.
Okay. Dad has a. What is this?
Very. Very. Very.
Oh, thank you.
I think the most interesting part about this, he's getting his lips together,
Mhm.
but he's not building up any intraoral air pressure to get kind of that oral airflow. He's still going with the weak pressure consonant of something that's easier for him, and that is the nasal.
Yeah. I mean, it almost has a hint of an M, a little hint,
Yeah,
but it's not. So you're like, what is he doing? Is it really a full M? Is it a B? I think
Yeah.
that's interesting to think about too.
all right. We now have the target is duck. Again, this is going to be some great examples of those mid-dorsum palatal stops. The difference between, again, a D and a K and a T, or a K and a G and a D and a K, a D and a T. Take a listen.
This is a.
Cat. That. That. That.
Oh my God.
Okay, so if you said it yourself, like Trina just did, you would have said dut. Dut. However, the first attempt sounded more like a K.
Mhm.
I don't think anything is a true K or a true T. I think it is a mid-dorsum palatal stop. And so again, if you were trying to transcribe that without knowing anything about the typical errors for kids with cleft palate speech, you're going to be like, what is he doing?
Yeah.
What is he doing?
Or
It's gonna
which
be-
one should I put?
Yeah.
Should I put a K or should I put a D there?
You can also see, I mean, this is a kid who has had therapy and been told to think about these sounds. And so he is trying to make the adjustments, but still really struggling.
So what I see too when I'm looking for, right, because we're looking for speech sound disorder, right? And our typical probably substitution for that K is a T sound, right? We can kind of sometimes predict that. But when you watch his mouth, he's not closing. It's not a K. I know that, right? But I'm watching his mouth, and his mouth is not closed for that alveolar sound. It's more open because he's using that middle part of his tongue.
Yes. And that's another really great point. So as you're looking, you know that he's not using, tongue tip on the alveolar ridge for duh, but he is using the broad sides of his tongue to stop that at the mid-dorsum palate.
Gosh, so important to listen and watch.
Yes. And I definitely love having him say it more than once. And like I said, I always encourage my students to try to produce it back in their own mouth, just like you do as you're sitting here listening.
Right.
Okay, one more.
This
Sorry
is
for my
a-
weird facial expressions.
Okay, let's hear this example.
This is his.
Dash. Dash. Dash.
Oh.
Okay, that's probably the best example of that pharyngeal fricative. You could hear kind of the air escape of the S, so he doesn't have, good placement of that S, but air is escaping because it's further back in his mouth. And then also, I mean, this is just an example of, You would think he would use the nasal
Mhm.
N, but he didn't. He used what sounded a little bit more like a D. So sometimes just when you think you can predict, you can't. You're looking for any kind of trend that you can possibly find.
This is
Okay, so again, I love taking the results of my tests and coming down to Trina's office and saying, what do you see? It definitely takes more than one person to kind of analyze and to find these trends. So I lay this on her desk, and this is where her brain goes.
So I first think, oh my gosh, there's numerous errors, right? Almost every sound,
Mhm.
there's errors. So that gets me to starting to think this is not my typical articulation case, right? Because if it was just a typical artic delay, there would not be that many sound errors. So that's where I go first. I think, gosh, there's numerous errors. What is happening? This is not my typical artic case.
Mhm.
Okay.
Okay.
So
let's chat.
let's chat. So I teach the speech sound class. So I always try to walk through, is it going to be phono? Is it apraxia? Is it artic, and why? So numerous errors I see, and I think, well, that could be phono. Because when you have a kid with phono, they've got numerous errors across classes of speech sounds and across your syllable shapes, like final consonant deletion, cluster reduction, right? So when I looked at his SPAT D and I looked for syllable shape errors, I looked at his final consonants, and he had consonants in the final position.
In every spot.
In every spot. Some of them were glottal stops, some of them were other substitutions. So I'm like, okay, well, there's not a primary syllable shape error. And then with phono, the next thing I do is I want to go to classes of sound. So the biggest class of sounds that I look at for phono is the fricative class, right? So in the stridents, your typical phono error is stopping. We're going to simplify the long sound and make it short and stop. Well, he wasn't stopping.
You all heard that.
Right.
For
There's
F.
airflow. There's airflow there. So he's not stopping. He's not showing that process. So it's not that he doesn't understand that he needs to make long sounds. He definitely gets it. He's just not making those long sounds in the right spot. And then I looked at his velars, because that's another, popular class of sounds. And he didn't really have consistent substitutions of the T and the D, which we would see for K and G. Instead, you saw those mid-dorsum palatal stops, and that's not typical for phono. So I'm going to rule out phono right now because I don't see a lot of rule-based errors.
Right.
Okay. So then the next thing I go to is, well, it could be apraxia. I did see and hear some inconsistent productions on his repeated attempts. So let's talk about why it's probably not apraxia.
And another thing that would potentially make you think apraxia is because he is severely unintelligible.
Yeah.
Especially on that first attempt.
Yes.
Yeah.
Yes. Very unintelligible. So he had a lot of distortions. We saw those on the SPAT D on the form there, a lot of distortion errors, or you could think about them as distortions, but actually they're compensatory misarticulations, right? And so with apraxia, we tend to see a lot of omissions because they're simplifying the word shape because they have difficulty with planning. So planning more complex syllable shapes is difficult for a child with apraxia. So they tend to simplify, resulting in a lot of omissions. Well, he had the syllable shapes.
He doesn't omit, he's always substituting.
Right. And we didn't see breakdown when he went to a multisyllabic word. There wasn't a breakdown, which we would see often in a child with apraxia of speech because of that planning component. And then I don't know if we said this yet, but his speech in connected speech, he shows the same errors, or he uses the same errors that he does in words.
Yeah.
So again, we would, in apraxia, you would see a breakdown there because again, the planning component. So we don't think it's planning. It's not planning that's causing his speech intelligibility issues. It's placement. It's placement of his articulators for those speech sounds that are causing those difficulties.
Because of his lack of articulatory contacts that he had for all of that time. So he has learned compensatory errors or learned bad habits that are substitutions for the target.
Yes. And now let's think about those inconsistent errors,
Okay.
because I feel like when you hear that and see that, you think, oh gosh, it must be apraxia because he's
Mhm.
inconsistent. He's making it different every single time.
Mhm.
Well, not every time. His first attempt was different than after a model.
Right.
So we had that discussion. His compensatory misarticulation errors are his bad habits, right? So to me, that's like an articulation error, like you're having a lateralized S. He's had speech therapy, and you're trying to get rid of that lateral S. Sometimes it still happens. Sometimes they use their bad habit, and sometimes they are able to use the correct placement. So my opinion on these inconsistent productions is that he's trying to reduce the use of that bad habit, and sometimes he's still doing it.
And we even said you could see him kind of think about specifically one time when he got a little closer on cookie, maybe, or duck. I think he actually started with the K-ish sound, and then he thought about it and went to a D. So he was trying to get closer to that sound.
Mm-hmm.
It wasn't that he was having trouble planning it consistently, but he was trying to improve the production with articulatory placement, which
Mhm.
because it was a motor placement error.
Yes.
Yeah. Yeah.
So we had to hash this out a little bit
did.
because they're like, okay, let's explain why it's not this and why it's not this. So
And then the last thing that a lot of times maybe looks like apraxia is that people tend to think that he's groping for positions. But if you think about his structural symmetry and how he does not have structural symmetry, sometimes it is difficult for him to get his articulators in the right place because of structure, not because of coordination or because of planning that movement. That's not what it is. But so groping, not really groping. He's just trying to get his non-symmetrical articulators to be in the right position.
okay.
Okay. Let's take
That
a
was
look.
fun.
That was. Let's see. Let's try this one.
Mhm. Okay, anything on this slide that we didn't hit in that discussion?
I think we got them all. Also, that his repetitions after he had the model tended to all sound the same. He does have some inconsistent resonance issues, even post-surgery. Again, those are learned errors. And then that last part at the bottom that we talked through in detail, does it matter if you have the right diagnosis before you start treatment? Does it matter?
1,000,000% yes.
1,000,000% yes.
You have to have right diagnosis to do that right treatment.
Okay. Let's see. So, in summary, we know that he had PE tubes placed at 4 months. Again, this is good news because prior to his cleft repair at 11 months, he did not have functioning muscle insertion. So therefore, his eustachian tubes were not opening and closing, and they were smart enough, knowledgeable enough. I didn't like the choice of words there to insert those PE tubes early so that he did not have otitis media, also kind of interfering with his learning of speech sounds. His oral mech showed deficits in structure, function, and dentition. The speech sound assessment that we use for SPAT-D and as well as the copycat showed us that he has limited phonetic inventory, no concerns with syllable shape. He has compensatory errors, including glottal stops, mid-dorsum palatal stops, and pharyngeal fricatives and affricates, and then also distortions like nasal emissions, hypernasality, and weak pressure consonants. He was stimulable with a model and repetitions as well as direct instruction for placement. So that's really important to know as we start to think about our diagnosis and then following that, our therapy. So this is a picture of our front page of the profile, our copycat profile. You can see that we have distinctive features highlighted in the articulation structure. He's got structural deficits. There's just nothing really else you can do with that. It is a fact, and it's kind of the most important kind of piece to this distinctive feature. So we checked that. He also does have a majority of sound errors. not related to planning and not related to weakness. So we checked that too. So we have things checked in the distinctive for our tick non-structure and our tick structure. And then in descriptive, the things that stand out are his resonance errors, the weak pressure consonants, poor intelligibility, and also that limited phonemic inventory. If you do all of those checks and you kind of think about what those descriptive features are, those descriptive features are going to be your goal areas. Those are the things that you're going to have to work on. So that's why I love having those descriptive features. The distinctive is what kind of gives you your diagnosis, and then the descriptive features are what you use to plan your therapy. So if you look over to the right, we know that this is our tick structure because of the structural deficits. Again, that's all you really need to know about that.
And I also think the descriptive features, it personalizes it to that kid.
Mhm.
That's what their speech sounds like, right? That those are their features of their speech sound disorder.
Right. And I love that seeing it like this because it just kind of highlights those things so that you make sure you're thinking about each of those features as you're trying to describe your client's speech.
Okay. Let's go to our handout now. So we're through our etiology, we're through the profile for this child. And now I'm going to ask Beth, since this is her client, we're going to talk about impact. So we have these areas listed on our worksheet. So Beth, is auditory comprehension impacted?
I don't like it when you start with that because my answer is I don't know. I don't know yet.
Okay.
I'll tell you why.
Okay. How about oral expression?
Yes, it's a problem, a concern. It definitely is impacting him.
How about speech?
Yes.
How about social?
Yes, he's not really communicating with anyone because no one can understand him.
And then how about EF cognition?
It kind of ties back up with auditory comprehension. I just don't know. I'm big on this whole idea of ability versus performance. The way he performs, I would have concerns for cognition and executive functions. I just don't have a clear picture of his ability. And again, I think we'll talk a little bit more about why I'm not sure.
Okay. Sensory?
It was reported on his case history, and so we definitely have it highlighted in our impact areas. However, it does not interfere with my treatment.
Okay. And written expression and reading comprehension?
Not yet.
Not yet. He's in kindergarten.
He's in kindergarten.
Okay. So clinically, we need to think about how this impacts this child. And what impairments do you think most impact his daily function?
Speech intelligibility, for sure,
Mhm.
because that really leads to a lot of shutdown and frustration for him. So I would say speech intelligibility and then just his motivation to want to communicate, his motivation to participate in therapy. Those are our biggest areas of concern for him.
Okay. And what activities are the most important to the client right now and the family?
Yeah, I think for family, they're going to tell you they're worried about academics and they're worried about social. Both of those things are really highlighted in kindergarten now. So I think they were concerned if he was going to be able to do kindergarten based on how things went in preschool. And here we are in kindergarten, and there are still concerns in both of those areas.
And what current characteristics hinder the client the most?
Yeah, I think, I hate to say behavior, but I think behavior because attention and motivation and willingness to participate, his absolute frustration for not being able to match kind of expectations for you is, and so then I come back again to that ability versus performance. His performance would make you concerned. I think his ability is better than his performance.
Tell them about the PPVT.
Yeah, just gave him the PPVT the week before last, and the clinician started it, could not hit a basal, started at his appropriate age, went backwards. He was just literally hearing a word and randomly pointing at pictures. She got all the way back to 1 and had not achieved a basal. So I went in to kind of assist her. So, no longer, again, we don't have a good, valid representation of his cognition, his verbal kind of IQ. We just don't know because he doesn't participate. When I went in, I really got animated. I gave him something to point with, and I would stop him and say, no, which one? And then he started just telling us the number. And, I would say, which one is twig? And he would say number 4. And we'd turn the page. Which one? I had to then kind of redirect him back after maybe 2 or 3 pages and get him back to that motivation of doing it. I had to change up. I had to be highly animated. It took a lot of effort. We couldn't even finish it in that session because he went so far. So he never hit a ceiling. We had to come back the next day to do it. I think we got a better picture of ability, and I think cognition is okay. I do. I think cognition is fine, but it takes a lot of effort and a lot of work.
And probably in the classroom,
There's
they're
no way.
seeing the same thing.
There's
He's
no
right.
way.
He's not participating. He's not answering questions.
Actually, we had an email from the school SLP saying that he will answer incorrectly on purpose. And they're like, we don't even know why we're saying that because it doesn't seem, logical for someone to do that. But I think he has such frustration for his lack of success in communication at this point. And then also, I will say that I think there's also so much confusion between parents and SLP at the hospital and SLP at school and SLP where we are. I feel like, that he's getting kind of different ideas from different places. And I think he is confused.
And maybe a little burnout.
And definitely, I'm sure, burnout. Okay.
Okay. What current characteristics are strengths to build on?
Hey, let's say cognition. I think that his cognition is good. And then I will say that very recently, like January, February, he has been participating. He has been being productive in therapy sessions, having fun. He's having a really great spring here at our clinic, and I think it's going to pay off.
I bet you were a little concerned and worried about when you thought cognition might be an issue, that if he was going to be able to self-monitor and fix his compensatory errors in the moment. But thank goodness it's not.
I really think cognition is going to be a strength for us. I think that, we have to find ways to motivate him intrinsically for communication.
Okay. So now we need to talk about goals and client-specific intervention. So with any client, as you are working with them, you do your assessment. You are hopefully then thinking about the impact, like we thought about with V here, and thinking about, well, what areas does it really impact them? What are their strengths? What are their priorities? And all from that, you're going to start to think about goals. And then how are you going to go about figuring out what goals to write? Where are you going to start?
I was first exposed to Cleft Palate speech 20 plus years ago. And so I have kind of a framework that I work from. This is the book that you can see it's well loved. This was kind of my starting point as far as finding the right framework.
Will you say the name of it and
I will.
author?
Therapy Techniques for Cleft Palate Speech and Related Disorders. And Karen Golding Kushner is the author. I call it my little green book, and we'll show it at the end, maybe in a bigger video.
Okay.
But as we were preparing for this, so I've worked my framework and kind of ideas and principles from that green book, and a lot of clinical experience in the area. But I wanted to know what the most recent kind of framework was. And so I was happy to find this article by Kotlarick and Kruger from 2023. And it had outlined some principles. So I modified those principles, and I have kind of 8 main principles listed here for you to help you design your therapy from beginning to, progressing all the way through to the end. The most important thing to recognize is that cleft palate speech therapy is supposed to be simple and quick. And so following surgical management, it really should be quick and easy. If it's not, it's probably a you problem, and you're probably doing something wrong. You're probably thinking about the wrong kind of things, providing the wrong kind of therapy or feedback. And so you need to reevaluate. And so these principles are going to help you do that. So I'm going to kind of talk through the principles.
I'm going to jump in real
Yeah.
quick because one thing you said was following repair, that intervention should be pretty quick after that. We haven't talked about his repair. So V's
Oh,
repair
yeah.
of his cleft palate was in 2020. And so
COVID.
after his surgery, he didn't have any follow-up with the cleft palate team. So I think that obviously is playing into what's happened with this kid, right? When you don't have follow-up from your cleft palate team, you're not getting that
Continuity
specific
of care.
guidance from that entire team, like the speech pathologist, the pediatric dentist, the social worker, the surgeon. Who else am I missing?
You said plastic surgeon, the orthodontist, pediatric dentist, audiologist.
Yeah.
Yeah, and speech therapist, of course. Unfortunately, or fortunately, I don't know, the plastic surgeon is usually the head of that team. And sometimes they're the only person on the team and they call it a team. So when you do consult and collaborate with a cleft palate team, you want to make sure that all of the people that we named are part of that team and part of making the decisions for that continuity of care outside of the hospital. And then also following. I mean, typically kids are seen, every 6 months for, maybe 10 years following their cleft repair to make sure that everything is progressing as it should, because there will be follow-up surgeries. There will be orthodontics put into place. There will be, dentistry going on as a pediatric dentist might need to expand or whatever they might need to do. So very important. And he did not have any of that.
Yeah. So I just want to throw that in there. We got to keep going with intervention, but I wanted to point that out.
So walking through kind of some of the principles, you first need to choose the appropriate treatment approach, and you're going to choose it based on the kinds of errors, the number of errors that they have. And you want to make sure that you're focusing on what were the prevalent compensatory misarticulation errors. I need to start there. If glottal stops are the most prevalent compensatory misarticulation error, that is where you start. It's the one that's going to interfere because it sounds like an omission, and it's the one that's going to interfere the most. So you want to start there. After that, you really want to think about beginning front to back. So the progression is different than developmental articulation. So you're going to do front to back, mostly because they're most visible and they're easiest to teach. You're also going to make sure that you are talking about the difference between oral, nasal, and glottal sounds. So you want to make sure they understand from a very early age. So if they get their repair at age 1, you want to start talking about the vocabulary: nose, mouth, throat. We have nose sounds, we have mouth sounds, we have oral sounds, we have nasal sounds. You want to make sure that you are educating them so that they can benefit from the feedback that you give them. You want to make sure that you're early on asking them, was that a good sound? Or was that one of our throat sounds? You want to make sure that they're able to self-evaluate early. You want to start with consonant vowels, but as quickly as possible, you want to move to words and functional phrases. You want to use multimodal cueing and feedback techniques. So you want to use the mirror to show if they are fogging the mirror. You might want to use a seascape for biofeedback. Visuals to show where the tongue, should go. Therapy for cleft palate speech, again, should not be a long time, but you need to do it very often with regards to frequency and also high intensity repetitions in each of the sessions. And this probably should be the number one thing. And I hate that it's at the very bottom, and that's my fault. I should have moved it up. Education to parents. Parents need to know what kinds of feedback or techniques you're using with their child. They need to know why they're making the errors they're making so that they can follow up on those at home. So you have to establish a home program so they know what is a good sound and what is a bad sound and what they should encourage and what they should ignore. It's really important to include parents from the beginning and all along. The second kind of piece to the framework is how do I select and sequence our targets? Again, I mentioned that it's not normal developmental, progression. You're going to use this suggested therapeutic progression for phonemes, starting with H. And you're using H because you want aspiration, you want oral airflow, you want to make sure that they have that before you do anything else. Then you're going to move to the vowels and pair that with your H, moving to W's, M's, P's, B's, Y's, N's, TD's. The ones that are bolded are kind of where we've been and where we are currently. So we're about halfway through with V. We still have, some phonemes to go. With regards to specific goals and where we are right now with V, his goals are these: accurate placement and production of bilabials in all positions, words, and phrases. You can see that we also have alveolars. If we do still hear any glottal stops, we want to nip those right away. So we always have a goal for kind of listening for and correcting those. And then also established phonemes. We want to put those in functional phrases as soon as possible. So he has functional phrases like help me, because he already has the H, he already has the M, he already has the P, no mom, because he already has the N, he already has the M. We want things that he can generalize outside of our therapy room that he's successful with. So it's one of my favorite parts is kind of taking his established phonemes and then putting them into functional phrases that we can play with. You'll see at the bottom that there is a little asterisk that said following surgical repair. By the time, they are 5 years old, after surgical management, we really should be done. They should have typical speech at that point. So, it's kind of a goal for you, inspiration for you, a challenge for you. I've got a lot of work to do in those first, kind of 5 years. I have a couple of examples here of videos. I just want you to hear a little bit of a treatment session. So I'll let it play. I might stop it along the way. We'll see.
Should we blow a really big one?
Okay.
First, let's put in. I will.
Pop. And
Try again.
pop. And
There was your tongue tip.
pop. Pop. And
Nice job using tongue tip for put and in.
pop. And
Try again.
pop. And
Make sure we hide our tongue tip
pop.
behind our teeth. There you go. Your tongue tip is hiding. We used our tongue tip to pick up Smarties.
Put and
Try again.
put and
There was your tongue tip.
Love that she's using one of those principles and really using that specific feedback about placement.
And important because parents are watching these sessions, so they get to hear the exact feedback that she's using and they know exactly what her expectations are. I also love that she's like moving her body so she can see inside of his mouth, because she's not just listening, she's looking for accurate and precise placement. We used to say just put your tongue behind, but now we say tongue tip because that was a specific error that he had. Also, look at the productivity and the participation. He is maturing, he is doing better, and that is a very functional phrase that he is having a lot of success with. Okay, one more, just a quick example here of him working on final D.
Can you and Milk help me turn the pages? You can? This book is called I'm Bad. Can you say that?
I'm bad.
I'm bad. Milk, can you say that?
I'm mine.
Yeah. Remember.
Okay, we like this example because you get to hear some of the nasal emission and the weak pressure consonants that we really haven't gotten a chance to spend a lot of time talking about. But that example, I'm going to just play that very first part one more time, and you can really hear it almost sounds like hyponasality, but it's actually that weak pressure consonant. I'm out.
Can you and Milk help me turn the pages? You can? This book is called I'm Bad. Can you say that?
I'm bad.
I'm bad. Milk, can you say that?
I'm mine.
Yeah. Remember to use tongue tip for bad.
Mine's
What's this book called? I'm
bad.
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 Yeah, I'm bad. Ooh, I see a dinosaur and a...
Okay, for time sake, we'll probably stop there and move on to just our summary statements here for client-specific intervention. You know, it really is a similar treatment approach to articulation. It actually is articulation. It's just based on structural deficits. So we're definitely thinking about placement. You have to make sure that you are knowledgeable and thinking about compensatory misarticulation errors. As soon as you see cleft lip and palate in their history, you need to read up on what compensatory misarticulation errors are. You have to address airflow, which is different than articulation. You have to think about mouth sounds and nose sounds and throat sounds. And then also just really understanding that a misdiagnosis of cleft palate speech for, say, phono or apraxia is definitely going to impact your progress, and you're probably not going to be making the kind of progress that you are hoping for.
I think too, even with just traditional articulation therapy, if you were not considering cleft palate, I mean, one of your principles were that you cannot follow the typical developmental progression. So I think if you're not digging in to that literature and figuring out what you should be doing for that specific diagnosis, even if you're doing artics therapy, it could be not effective,
Right.
Because you're not applying one of those principles.
Right. Okay, we are ready for some questions if anyone has any. You see here on the screen as we look, some ways for you to find us on social media if you have any questions or want to know anything more specific about a client. Okay. We have the SPAT-D question, and another example, someone was asking about our visual. So I think for our worksheet, and you should have been given that through Speech Therapy PD, they should have shared the visual, a blank one, as well as the one that we had filled out for.
It might have been a visual of your compensatory misarticulations. Let us know what visual.
Let us know what visual for sure. Okay. All right, we are, if there are any other questions, go ahead and put those into the chat and we will be sure to talk to you about that. Something that people often want to know, okay, sorry, the compensatory visual.
Okay.
So the phonetic transcription? Is that what it is that we're
Yeah,
asking?
with the,
Okay.
yes. And then they posted the blank form twice. Okay. We will let the people from Speech Therapy PD know that so that you can download the filled out handout.
Yes.
Sorry about that. We'll make sure that they get that posted so you can access that. That filled out handwork does have the framework that Beth talked about at the end and the principles, so you will have information about cleft palate intervention. Somebody put that they do see the filled out one.
Okay, take
Okay.
a look. I also just put my email into the chat if anyone wants to jot that down, and I could send you the compensatory misarticulations, or at least the best resource for that. Sometimes people want to know, how do we go about, the whole collaboration piece if there is disagreement in diagnosis. And, it's just, education, and we're just trying to educate. The thing that never came up again, except from the beginning, is the AAC device. I was really at the very beginning trying to encourage parents that, I would rather him practice his speech than use his device. And so, I think it's just having those conversations. It's not been an easy conversation with this particular client. And so it's really on me to just continue with that education piece, not just saying, I would never just say, you're wrong, I'm right. But I feel like if we're not going to be on the same page with our treatment approach, it's going to hinder our progress.
Yeah, and it's got to go back to that diagnosis. So I know Beth has years of experience with cleft palate intervention. I do not. But walking through this epic case study and the way that we have it laid out and thinking about all the different pieces from the etiology, which is obviously huge for this particular case, really analyzing that profile for the diagnosis, and then digging in. That client-specific intervention, you've got to dig into the evidence. I can't just do traditional artic therapy for this kiddo. So understanding those principles will help guide your goals and guide your intervention.
Somebody might also say, well, could it be both? Could it be cleft palate speech and apraxia? It's probably never going to be that. Never is a strong word. But let's say it was both. You still can't only do apraxia therapy and get results. You're still going to have to address those compensatory misarticulation errors because they're there. You heard them. So even if it is both, you still need to address the placement.
Placement, absolutely.
Yeah.
Okay. I don't see.
We must have answered every question tonight.
Okay, so scroll up in the chat. The email is there. We also, if you find us on our website or if you follow us on Instagram, you can DM us and we'll get you the information. Just look up B&B SLP and you should be able to find
Go
us.
back to resources really quickly.
Share that.
I do.
Share the screen.
How do I get back to? I'm putting the resources back up here. I will tell you that the Peterson-Falzone resource, you see it maybe the third one down, has all of those compensatory misarticulation errors explained with diagrams and the phonetic transcription in a very easy way. So you might check out some information from Peterson-Falzone in the meantime, but I will be happy to send you some information specifically on that as well. If you email the BL Bergstrom at eiu.edu, we will get back to you.
Okay, and we hope that you guys enjoyed tonight's session. And then you can also join us next month. So we have an epic case every month. It's the last Tuesday of the month. And we are going to be doing one more speech sound disorder case before we move on. And we think it's going to be tongue tie. Well, we know it's going to be tongue tie. We're going to be talking about tongue tie in a month. So we hope you join us then. Thank you so much tonight for being with us.
Thank you.